அடிச்சுக்கோங்க. இந்த கை வச்சு அந்த கை வச்சு என்ன மாசம் சொல்லுங்க.
This will observe you what he is doing and try to correct that, or what are the requirements for the examination of olfaction.
அதையும் கொஞ்சம் இங்கே கொண்டு வைக்கிறேன். என்ன வாசம் தெரியுன்னு சொல்லுங்கள். என்ன வாசம்?
மெடிசன் வாசனை.
He was trying to show some sort of substance and trying to find out what exactly substance is trying to show by only making the patient to observing his inhalation of olfactory function capability. But what are the requirements for checking for olfactory? Prerequisites.
Patient should not have any allergic rhinitis, upper respiratory tract infection.
So should not have any immediate past allergic response to the form of or infections.
Yes. Trauma.
The other requisites.
Be familiar with the smell of smell.
That's very important. Familiarity of the smell is very, very important. Familiarity smell of the audible. Familiarity of the smell should be there for the individuals. Suppose we are showing a different substance which is not familiar with, you might say the answer is like medicine like, or whatever is telling the answer is feels that the substance is shown to him is like a medicinal product. It is not really. Okay? So it's very important. Even you can show the patient whether he is able to identify the object also, substance also is very important. After this, you are not going to show the patient the substance. We are going to ask the patient to close the eyes, then only throw the substance into the nostril area. Okay. So in that case, it's very important to show the substance and ask him whether he is able to identify the substance or not, so that he will not make a blunder mistake of medicine as it is. Okay. Anything else? Prerequisites. Similar to the allergy, just have a look at the nostril part, especially antenaris part. Is there any evidence of polyp is there or not? Which is really obstructing is normal. You cannot say it's a olfactory nerve dysfunction, because you're trying to identify is really olfactory nerve dysfunction or not by not looking at the local reasons, without which you cannot claim that patient is having a olfactory nerve. It's going to be major nerve dysfunction. So which is not the way to look for. Then anything else. Never keep some irritants. So never keep any irritants for the identifying the nostril part, especially for the olfactory function. It is going to produce stimulation of the pain receptors or nociceptive receptors, and it will not produce the real receptors to be stimulated for the sensation of the smell. Then anything else. Make the patient bit comfortable also, making a patient sit inside of so much of crowd. Some bit nervous, you might tell a wrong answer. It may not be the case for the patient's olfactory function is concerned. So really important, looking at this small important points, so that you have a bit of clear idea that are we really checking for the olfactory function or not. Okay? And keeping the substance very, very close, especially powder form, sometimes can produce more irritation. So just trying to avoid those type of, even though coffee is going to be only powder form, we cannot make it as a liquid form, but even then carefully handle the substance. Okay? So now I can show you whether it's able to identify the substance or not. Ask it to smell it. He's trying his best to smell, but he's not able to identify what substance is been kept.
He's saying it is medicine. Nice.
கிராம்போட வாசல் எப்படி தெரியுமா உங்களுக்கு? தெரியும். Probably would have used the substance for long months or years. From second year onwards, same substance without changing it would have gone off. The smell would have gone off. If you ask the patient whether they are able to smell it off, you cannot smell it. You know that they are keeping it for 2.5 years. But at this time of examination, you cannot expect the patient to smell and find out what substance it is, right? Not practically, you can think about that aspect also without blaming the olfactory. Because very rare occasions you get individual isolated olfactory nerve dysfunction. Basic point is try to understand at undergraduate level and postgraduate level also. It is not an easy one to have a pure isolated olfactory nerve dysfunction. In that case, we have tried our best to make effort to avoid a wrong diagnosis of olfactory nerve dysfunction. This is a very important point you take home. Because undergraduate, postgraduate level, it's not an easy task to get a isolated olfactory nerve dysfunction. It is not a common thing. It is not common. Okay. So few points you should take home from the olfactory nerve. Don't keep irritants. Number 2, patient should be familiar with the substance. Local examination has to be carried out before doing the proper examination of the olfactory nerve. And we can make the patient to have a look at the substance also. It is not wrong idea. But at the time of smelling, we should not ask the patient to keep the eyes open. That's very important. Okay. So the few requests we are supposed to do. Okay, we move on to the second cranial. Third important, last important point is check for one nostril, follow the other nostril. It's very important. Okay. Yes. Second cranial.
Second cranial, optic.
What are the components?
We have to check visual acuity, visual field, color vision.
Yeah. 3 important parts are visual acuity, visual field, and color vision. What are the prerequisites for visual field and visual acuity?
Visual acuity, we have to check both near vision and far vision. And for far vision, we have to use Snellen chart. Ideally. The patient should be 6 meters away from the Snellen chart and start reading from top to bottom. If the patient is able to read the last line, his power is 6/6. If he is not able to read, we have to ask the patient to move forward by 1 meter until he can read the last line. If he is not able to read even after reaching 1 meter, we do finger count close to face. If he is not able to do, we do hand movements, and if he is not able to do that also means we have to do a perception of light.
So these are the order of checking for visual acuity, especially for long vision or distant vision. So short vision, near vision.
We have to use J-Gus chart.
Distance. How much? Yeah, 1 feet distance. 1 feet distance, 25 or 30 centimeters near vision examination site. Is that anything else? Similar to that, the order of examination also very important. Ask the patient to look at the last line, then start from the above down to assess the power of vision or visual acuity of the individual. It's very important. The distance has to be maintained. But practical purpose, exam point of view, you cannot expect to have a examination room where you can make the patient to sit 6 meters distance or 6 feet distance. You cannot do that. So we have some sort of practicality of some sort of keeping some sort of bedside and chart which can be kept at least 1 feet or 1 meter distance. You can do the examination. It's very important. Okay, practical purpose, exam point of view. Okay, yes. And then visual field.
Visual field, we have to check first both is simultaneously, and we have to test it individually also.
Where is the position of the examiner? Where is the position of the patient? It's a very important point.
Patient should be in front of the examiner, and the distance should be 1 meter apart.
1 meter, yeah, you can do that. Okay.
And our examiner hand should be at an equal distance from the patient.
Eyes also. Okay, then.
Patient should not tilt his face while examining, and his eye gaze should be fixed towards us.
So the visual field examination is very important. Instruct the patient clearly that the eyeball should be moving, not the head movement. Should be clearly moving only eyeball, not the head movement. Okay? Yes, then it will show me that properly position yourself. Always reach.
என் கண்ணை மட்டும் தான் நேராக பார்க்கணும் சரிங்களா தலை வந்து நேராக வச்சுக்கோங்க என் கண்ணை மட்டும் பாருங்க நான் ரெண்டு கை வைக்கிறதுல எந்த கை இந்த கை உங்களுக்கு தெரியல ரெண்டு கை தெரியுதான்னு சொன்னேன் ரெண்டு கை தெரியுதா இப்போ நான் ஏதாவது ஒரு விரல் கண்ணு திருப்பக்கூடாது என்னை மட்டும் நேராக பாருங்க நான் ஏதாவது ஒரு விரல் ஆட்டினேன் எந்த விரல் வந்து உங்களுக்கு அசைக்கிற மாதிரி தெரியுதோ அந்த விரல் காமிங்க சரியா இன்னும் அசைக்கல எந்த விரல் அசைக்கணும் அந்த விரல் அசைக்கிற மாதிரி எந்த பக்கம் காமிங்க எந்த கை கண் மட்டும் பாருங்க என்ன மட்டும் பாருங்க எந்த கை விரல் அசைக்கணும் அந்த விரல் வந்து கை வச்சுக்காங்க நேரம் பாருங்க நேரம் பாருங்க
So what is the normal lateral vision or outfield vision? Maximum
100 degrees.
120 degrees. You can have the vision when you're going to look straight. You can have up to 120 degrees, 100 to 120 degrees is the angulation by through which you can have the normal vision when you're going to look straight. Okay? Yes. So suppose check for the field of vision, all the quadrants. It's very important. All the quadrants, suppose check for the, how are we going to divide the quadrants?
Superior, inferior, temporal.
Temporal, nasal. So the common division is lower. Okay, yes. Because you should be aware that there is a quadrant anopia and you have a hemi anopia also. These are the defects you can see. So just be familiar with. Check for all the quadrants. What he has assessed is binocular. Okay, field of vision. Now he is going to check for uniocular vision. Okay. So what is the defect here? So always bring your object or finger when you check for the uniocular vision, temporal field, upper or superior and inferior quadrants, always try to bring your finger. For the nasal field, never try to cross your finger to bring the object. Never do that. Always the examiner has to change his finger object this side and get close your with this and try to bring the object for the nasal field. Never try to bring for the field of vision. Never try to bring crossing the midline for nasal field of vision. Never do that. Okay? It's going to be very much easily can be picked up by the patient that you are going to bring in some object. So you can by clue or by some sort of hint you might say that yes, the object is there. So ideal one is to go for field of vision. You can do that horizontal, quadrant. Do this much is enough. And for the nasal part, you try to close your eyes with the other hand and try to bring without crossing the midline for the uniocular field of vision. The other finger or other side, the object can be brought. Okay, that's only change you have to do that. This for the field of vision. Yeah. Always try to bring horizontal quadrant. You can easily for the post-grad you always say diagonally you can bring in the fingers. It's easy for you to say that which quadrant is involved diagonally. Okay.
For color vision, ideally we have to use Ishihara charts.
Full name of it. Now you finished your ophthalmology. Right? Finished? Good, good. Fast. Very good. And without knowing Ishihara's full name. It's called as isochromatic chart. Ishihara's isochromatic chart. It's not trichromatic. It's isochromatic chart. Okay. What is it? But always make a habit, carry your kit. It's very important. Undergraduate level, postgraduate level, clinical examination. No compromise on the clinical examination. The quality what you are supposed to learn, what you are supposed to practice is not changed. UG or PG or even for the DM neurology also. No change in the clinical material is concerned. Always make it a habit to keep the Ishihara's chart with you. Okay? Including the Adler's chart and Jigar's chart also. Okay. So this is the basic examination method which you are supposed to keep in mind. The only point which he has made mistake is checking for the nasal field. Never try to bring your object crossing the midline. Number 2 is never keep irritant substance for the olfactory nerve. Examine the local part before examining, because to have isolated olfactory nerve dysfunction is a very, very uncommon thing. So always common things are common. Okay? Yes. That.
Then 3, 4, 6.
3, 4, 6. After checking the acute and field of view, going to check for the eyeball movement. Okay? Which is carried out by 3, 4, 6. What are the important terms you are supposed to remember undergraduate level when you are going to deal with 3, 4, 6? What are diplopia? Okay, good. Nystagmus. Binocular diplopia, uniocular diplopia. Okay. Ptosis, good. Partial ptosis, complete ptosis. Good. Squint. Strabismus. Then paralytic strabismus, non-paralytic strabismus. Each has got its own components. Try to remember these terminologies, because when you are going to learn next level, you should be a bit clear about what you are learning about regarding the type of problem what you are dealing with. What about the nucleus?
Third and fourth from the midbrain, superior colliculus and inferior colliculus respectively.
The eyeball movement is concerned, we have the conjugate movements, horizontal movement, vertical movement, right? And different types of musculature is involved, right? So tell me the important terms related to the controlling centers for this movement, especially for conjugate eyeball movement. What are the controlling things?
Parapontic reticular formation.
PPR of
Medial longitudinal fasciculus.
MLF. Okay, so MLF and PPR should know. Just when you are trying to learn about this clinical material, try to recollect your physiology. Whatever we discussed only physiology, first MBBS subject. It is not medicine subject. Okay, so you should be a bit familiar with. Even the clinical examination, what we are doing is part 2 of your physiology. That's why you learn about this, the learning of clinical examination. So you should remember these terminologies which are discussed about clinical pattern of diplopia or your other types of problem. Similar to that, you should remember the basic physiology of MLF and PPR. Okay, yes, go ahead.
Command the patient to look in particular direction and followed by
Before that, any examination always starts with inspection followed by palpation, then percussion, auscultation. This order of clinical examination never changed. Even for neurology. Okay? Yes. Because we told about ptosis, that's the reason I just asked you about, told you about the important terminologies or the terms you should remember. I told about ptosis, partial ptosis, complete ptosis. Then eyeball neutral position. That's what you can make out, is it a paralytic strabismus or non-paralytic? Squint is there or not, paralytic versus non-paralytic. Okay? So what is the eyelid position? What is the eyeball position? Always start that way. Okay? Yes, 3, 4, 6.
on the inspection there is no ptosis. Eyeball is in midline, there is no deviation of the eyeball.
Go. Sit.
Eyelids appear to be a little bit inverted.
So he is examining the patient, keep on moving his head, number one. He keep on moving his eyeball also. Always try to examine the patient neutral position. The patient tries to look laterally. Keep on moving his eyeball. That will give you a wrong idea that you might be dealing with some sort of wrong positioning of the eyeball. Keep on instructions to be given for olfactory, even for the second nerve and 3, 4, 6 nerve also. It's repeated reinforcement on the instructions to the patient to follow your instructions. Verify and check whether the patient is following your instructions or not. Sometimes gives you wrong information that patient might be having some sort of paralysis of the medial rectus or might be thinking that you are dealing with the lateral rectus palsy. Suppose lateral rectus palsy, what is the eyeball position? Lateral rectus position. Medially rotated. Medially positioned, not rotated, medially positioned eyeball. Because it's only horizontal movement. Rectus is going to produce, especially medial rectus and lateral is going to produce horizontal movement. It's going to position the eyeball into medially position. Okay? Or nasal side deviate. The eyeball will be nasal side deviated. Okay? So make the patient sit straight and narrow. Just you are going to look at the eyeball. Okay? For a fraction of a second is enough for you to pick up the eyeball position. Being the left eyeball, the eyelid is bit of more closer than the right side. So how are you going to make out? It's only the eyelid blocking or the covering the corneal portion that you are supposed to look for. Corneal portion. Okay, you have the limbus is there. Always 1/3 of the cornea is at most covered by your lid. Okay, usually you will not be able to see the upper limbus part. Usually you don't see the upper limbus part at all in normal positioning of the eyelid. Okay, it's going to cross your pupillary aperture area. It's definitely understood that you got a positioning of the eyelid bit more lower than the normal position. The patient also try to overcome that by how they usually overcome. The person is having a partially closure of the eyelid, blocking the head tilt. So always try to do that. And see the patients keep on instructed to keep the position normal or neutral position, not head tilted position. Sometimes it gives a wrong idea that patient's eyelid and other things are normal. Patient tries to overcome the partial ptosis by head tilting. Try to avoid it. That's the reason basic instruction is keep on check with the patients the positioning of the head and eyelid or eyeball position. Okay, go ahead. Yeah.
எந்த பக்கம் பார்க்க சொல்றோம்னா அந்த பக்கம் தலையை திருப்பாம கண்ணை மட்டும் திருப்பி பாருங்க. சரியா? உங்களோட வலது பக்கமா மேலே பாருங்க. வலது பக்கமா பாருங்க.
We're going to instead just tell me what muscle you're checking. Keep the patient's head proper. Once again. Yes.
வலது பக்கமா மேலே பாருங்க. வலது பக்கமா மேலே பாருங்க. கண்ணை மட்டும் வச்சு. வலது பக்கமா மேலே பாருங்க.
He is not understanding your instruction.
தலையை நேரா வச்சுக்கோங்க. கண்ணை மட்டும் நான் சொல்றது கேட்கல.
அப்படிதான் மேல அது இருக்கும் பாருங்க. இந்த போர்டு தெரியுதா? Still water is it. Right.
வலது பக்கம் கீழே பாருங்க. கீழே தலையை in this position, right eye inferior rectus and left eye superior.
You can also show some object, ask me to follow it. Instead of asking to say right lower side, left upper side, right upper side, just to show an object which is more attractive to you. whichever is there. Products of joints like you want to keep it, it's always easy for the patient to follow it. Or when on finger, whatever. Ask me to follow the trend.
இந்த ட்ரெயினை பாருங்க, நான் எங்கே கொண்டு போகிறோம், தலையை திருப்பாம நேராக வச்சுட்டு கண்ணை மட்டும் வச்சு நான் வந்து கொண்டு போகிற சொல்லி பாருங்க, சரியா? தலை திருப்பாங்க.
பேனாவே பாருங்க, பேனாவே பாருங்க. Correct. Yes. What is called this? Following. What the method is trying to follow? Simple alphabet. H. Okay. Roller.
தலையை நேராக வச்சுக்கோங்க.
So he often tilts his head. Okay. Especially smart patients, chronic neurological patients, they know how to manipulate. Especially for the postgraduate, be careful about that. You'll be in trouble. You'll manipulate and give you wrong information about the patient's problem. Always be more smart. Yes. All the fields they able to means the movement is happening. Okay. So suppose there is a defect. What are the cranial nerves 3, 4, 6? What are the muscles specifically supplying? SO4 and LR6. SO4. What is the function of primary function of SO4? Intorsion. Yes.
Elevation of adductor eye.
Correct. So obliques always elevation of the adductor eye. Okay, it's very important. Whereas recti?
Recti adductors and elevation of abductor.
Elevation of the abductor eyes. Okay. Okay. Then reflexes. What are the reflexes? Two important reflexes. What are the prerequisites? That one. Yes.
Patient should look forwards. He should not take his head.
The patient should be facing forward, looking straight, not looking to the light source. Not looking to the light source. Very important. Okay.
We have to project the light from the artery
Actually,
and look for first that light reflex. We have to look construction of the same way, same people, and then we have to look for indirect light reflex.
you have to keep on supervision. Here, never try to bring the light source directly into the field of vision. Never do that. Yes. Now he's trying to look for reflex. Throwing the light on one side, looking for the response on the other side. Because of why? What is the response you expect on the left side? So do it towards the light on the right side. So both sides construction is expected. It's because of the heading and responding today. What is happening? 1%. Bonus is always easy. Only 1%. Whatever you said, somebody 3-4 people said.
People are moving with the simulating
It's let this be homework for you people. Go and find out why there's a consensual light reflex. Even this is a smart UG program, lot of questions to be thrown to the students to go back and SDL, self-directed learning. Go and find out what are the answers for this question. Okay? We try to teach only clinical methods. Yes. So you should look for the consensual light reflex also. Very important prerequisite is never try to throw the light source directly into the okay. Opposite side also. Accommodation reflex.
Patient has to look at a particular distance, and we'll keep the finger in front of the patient. He has to look long distance for a particular time, and then he has to shift his vision towards our finger
Always try to bring the object suddenly in front of the patient, very close to his nostril, at least at this level. Not close to the nose. Never do that. Okay? Yes.
And we look for
Patient has to fix the eye field very distant level and ask the patient try to fix the eye field into the or vision into the nearby object. Okay?
we
What
look,
is expected?
look for convergence and meiosis.
So convergence meiosis is expected for normal response. Why it's happening? Go read about. Already we discussed a few terminologies, right? Few terminology we discussed about MLF, PPRF, the things why it's happening. Go read about. Yes. This is a basic requirement for demonstrating accommodation reflex. Okay? Yes. So 3, 4, 6 we finish, including your eyeball movement and your accommodation reflex, direct light reflex and indirect light reflex. Okay, that.
Moving to fifth cranial nerve,
Yes.
it is trigeminal nerve, mixed nerve. So we want to test both sensory component, motor component, and reflex
Where is the
component.
placement of nucleus for fifth nerve?
Pons. 3 nucleus.
Don't ask that. Never get proxy. Okay, you try to answer. It's an area or platform where you can improve yourself by answering the questions on your own. Nobody is going to answer for your examination.
Yes, the 3 nucleus, mesencephalic nucleus and spinal nucleus of trigeminal nerve, which comes from midbrain
What is the
to
extent of nuclei?
midbrain forms medulla.
Give me answer.
Midbrain forms
It's starting from lower midbrain, upper pons, goes to the level of C2 level. Somebody said C2, good. Goes to the level of C2. That's for the spinal part. The mesencephalic part is above the level of pons. This is the mesencephalic part. So wide, lengthy nuclei. Okay. So how are we going to check for it? I already mentioned about the components of the nuclei. You should remember that, and we should know how to check for it. What are the motor components? What's that? Motor component, sensory component.
motor component.
Somebody
It has
show
masseter.
what are the important muscles supplied by your
Masseter.
With all these finer muscles may not required to remember. At least the major one should know.
Masseter, temporalis, medial and lateral pterygoid
Pterygoid.
muscles.
So pterygoid and your messenger two important muscles should remember. Temporalis also. Okay. Yes. Go ahead.
First, motor system examination. First, we will inspect the patient whether any masseter or temporal area.
Where is temporal area? Where is temporal? Okay. This area is temporal area. Okay. Temporalis wasting is there or not? That is trying to look for inspection wise. So as I was mentioning about, always start with inspection followed by palpation. Okay. Yes.
Masseter muscle.
Okay. This palpation. Before going for the palpation, inspect. Okay. Now he's trying to palpate and find out the tone and the power of the masseter muscle. Pterygoid. Where do you palpate? Ask the patient to open. You'll be able to assess the power of which pterygoid? Lateral pterygoid, middle pterygoid. Lateral pterygoid. We're trying to check for the power of the lateral pterygoid. Okay. So first one is starts with without offering any resistance. Then try to offer the resistance. Find out what is the power of the pterygoid. Process. You're not going to grade the muscle power, but even it's always to go for opening the mouth followed by offering the resistance. Try to understand the quantity of power is offered to your resistance. Also can be assessed. Okay? Yes. Then another important motor part, especially for jerk, is concerned. Before moving on to the sensory part. Yeah, jaw jerk. How are you going to do that? Jaw jerk, the only reflex mediated by your fifth nerve. Okay, fifth nerve. So the prerequisites are slightly opening the mouth, Mouth should be kept open, not too wide, small opening. Then place your thumb over the chin portion and always instead the patient is trying to bring this object in front of his eyes and trying to some kind of strike over the chin portion will be very much frightened. So he has not instructed the patient what you are going to do. That has to be done, see to that the patient is comfortable. Any reflex getting completely abolished or completely stopped by your frightening way of examination. That should not be the way of examination. Try to be more comfortable. Always ensure that the patient is comfortable mode during your complete process of examination. Examination is concerned or your bedside examination, the ward rounds, doesn't matter. Patient is always patient. Human being is always human being. The tendency for fearfulness, suspicion also will happen. Because you're going to say, I'm a final year student, I'm going to examine you, then he knows how to treat you. So those things are practically expected. You try to be more friendly with the patient. That makes always any human being to come down from their level. Okay, it's very important. Try to instruct, especially going to check this type of movement examination, bringing an object, try to be more friendly with the patient. Insert the patient. Okay, what is expected?
Absent.
What is expected for normal response to jaw jerk?
Closing of.
Closing of the jaw or the mouth aperture will get closed by this, but never get misinterpreted that the vibrations happening of this jerk, what you are creating over the chin portion, is not a sign of response to your jaw jerk hesitation. Very, very important. Sometimes you get the vibrations, that is not the response. Okay? Yes. Then follow the sensory part.
Sensory component, it has ophthalmic division, mandibular division and maxillary division. Each one has to be separated individually in
What
both
is
sides.
telling the branches of fifth nerve? What is the important clue you should remember when you are trying to check for sensory examination of the fifth nerve? Which is often used as a clue for clinicians to avoid the malingering of the patient's nature. Cornea cannot be manipulated by the patient. Sensory part is concerned. Okay, we are not discussed about cornea conjunctival, but we will get to that later. The reflex part. But before that, sensory part is concerned. The important clue should remember, he was mentioned about three branches: ophthalmic branch, maxillary branch, mandibular branch. There is an area called the angle of the mandibular area. This area goes up to this level, supplied by this angle of the mandible. Small portion is there. It is not only this, but goes back and supplied by C2. Good. It's supplied by C2. It's one of the important delineating point between the true abnormal finding of fifth nerve involvement versus malignant patient. Okay. Usually it is not supplied by fifth nerve at all. This portion, angle of the mandible, followed with this area back, can be supplied by C2, then C3. Okay. What is the C1 area?
Meninges.
What is it? Energetic cancer. Yes. Come on. Right or wrong doesn't matter. It's very important to have the courage to talk. No dermatome is the answer. There is no dermatomal distribution for or supplied by the C1. Very important. Okay. So C2. So C2 starts from here to this level. Then C3 is here. So this area, when you try to check for the individual branches, ophthalmic, maxillary, mandibular, you can also verify this part. Or the other way to check for sensory part is, anybody knows? Postgraduates? How to check for sensory component of the fifth nerve? One is branch, ophthalmic, maxillary and your mandibular. The other way to, what is black lava? Pattern of anesthesia. Pardon? facial. All these fancy names bit of familiar and very interested to know. Common things are bit of lacking. Yes, fancy name you can remember. It's easy for you to declare. So always there are two ways to examine sensory part based on the distribution or placement of the fifth nerve nucleus. I was talking about the three areas, lower part of the midbrain, pons and your up to the level of C2, that is your the spinal part and the mesencephalic part, starting from the tip of the nose to the level of trans. Starting from medial to lateral or lateral to medial. Okay? So medial to lateral or lateral to medial. You can also check where you can get the expected onion peel skin appearance of sensory loss in case of fifth nerve. It's called as onion peel. It's like the distribution is going to be like this way, so it's called as onion peel. So you can make out whether the problem is at the midbrain level or at the C2 level. That is your mesencephalic part is involved or your spinal part is involved. Okay? Starting from here to this level. This is your spinal part involved. This is your the mesencephalic part is involved. So by that you can also distribute. So you can check whether any clinical features related to the mesencephalic part, midbrain, pontine part is involved for the clinical other features. Will add value. So sensory examination is concerned at undergraduate level. Try to check for ophthalmic, maxillary, mandibular, good. Never forget about the C2 distribution at the angle of the mandible. And very important, also think about way of looking for onion peel from the tip of the nose to this one. Okay? That's how we are going to check for the sensory examination of the fifth cranial. Okay? Yes. Cranial conjunctiva. The other two references we have not discussed. Good.
So corneal, for corneal and conjunctival reflex, first you want to instruct the patient what I'm going to do, because it may be a painful or irritation of the patient. Next I will ask the patient to look outward, and I will bring the cotton, base of cotton from lateral side. Then
Yes.
I will slightly this to the conjunctival corneal junction.
Touch the corneo-conjunctival junction. Okay. Never try to bring the object to the visual field of the individual, number one. Number two, never try to touch the center of the cornea. Never try to touch the center of the cornea. Okay? Always try to go for upper part of the cornea is more sensitive than the lower part of the cornea. So when you say lateral, just try to go for the upper part of the lateral cornea. It's always more sensitive area to pick up to avoid the reflex of what you call withdrawal-like response can be avoided. Okay? Yes. Then conjunctival. Similar to the conjunctival, but conjunctival is very less sensitive and less specific compared to the corneal reflex is concerned. What is expected? Bilateral blinking response. It is not unilateral. So bilateral blinking response. Okay? This is for the fifth round. Of the reflex is concerned, Georgia, corneal conjunctival. Anything else is there? Any other reflex? Postgraduates. Fifth round is concerned. Any other reflex? Fifth round, anything to do with the soft palate? Is by only fifth round?
No, ninth.
Fifth now.
Then you are not answering. Okay? Yes. So these are the few reflexes to remember the fifth nerve is concerned. The only seventh are very important one.
Seventh now.
I think I covered all the parts of fifth nerve. Yes.
It also has sensory motor component. In motor component, first we instruct the patient whether there is any asymmetry of the face or deviation of angle of mouth, or whether the blink responses.
Always try to look for the forehead part, nasolabial fold, angle of the mouth. These three areas. Okay? Yes. What is the additional part you want to check in the case of seventh nerve? After doing the important conventional examination of the inspection motor part. Anything else? Stapedius? Always ask for history of hyperacusis lacrimation, special sensations of the taste sensation, anterior tooth thread of the taste. Because you often forget to do this examination. Always opt for the lacrimation part, then for your salivation part, then followed by your taste sensation. Always try to look for. Okay, and hearing, hyperacusis, another important one, often missed. Because you will be knowing that the forehead part we look for, nasolabial fold, blowing of the cheek, all those stuff, but you often forget to look for the history of and examination of the hearing and the taste sensation. Okay? Yes. So how to differentiate UMN from element?
So upper part of the face is in what means it is element.
The answer should be 1/2 of the face is involved in case of element. Okay. On the same side or opposite?
Opposite side. Same side. Sorry.
Morning you did breakfast? No breakfast? That's what the problem is. Huh? You had a breakfast. I had my breakfast. Good dosa here. Okay, go ahead. Show me the examination important parts. Holding the patient's head is to be very, very carefully handled. Especially when you are going to appear for a membership exam, you will be fired by the patient without getting the permission to hold his head. Okay. By the MRCP patients, membership exam patients. You also have the centers in Chennai, so be careful about handling the patient, especially the way of handling is very, very important. Irrespective of the examination, bedside examination, regular ward classes, doesn't matter. Make a habit of examining the patient in a proper method. Yes. He's trying to look for which muscle? Frontalis muscle. He's trying to look for the frontalis muscle. Okay. Too tight. Correct. You have to tell him that you are going to open up the lid. Don't allow me to open the lid. Ask him to close tight, and you are going to say to the patient that I am going to open up the lid. Don't allow me to open up. So that you will be able to keep it too tight and constantly maintain the tightness. Okay? Yes. Which muscle you are trying to look for? No play. Which muscle? Sorry, which nerve is supplying LPS? Third. Yes. Good. He's trying to check for blowing the cheek. Which muscle? Buccinator. Trying to check for the buccinator. And ask the patient to blow up the cheek and ask him to keep it static. You are trying to push the each part of your cheek and try to find out the tone of the buccinator or power of the buccinator. Then you are expecting the nasolabial fold will be obliterated on the side of the disease. Okay? Yes. Which was you trying to look for? Orbicularis oris. Okay? Yes. That, I think that much. Taste sensation. Show me the taste sensation. If you are able to remember these 3-4 muscles, it will be far enough. But just check for how to check for taste sensation. At least tell me what are the prerequisites. It is not come prepared for the taste sensation exam. We come prepared. Not prepared. Okay, tell me the prerequisites.
So for taste sensation, ideally we should ask the patient
You
to
should.
protrude the tongue.
Not the team. Yeah. There is no teamwork in the examination. It's always individual. When you are going to tell the examiner, so I will always ask my patient, sir. Never do that. We. There is no we there. Single man. Okay. Yes.
I will ask the patient to protrude the tongue. Before that, I will prepare 4 types of taste solution like sweet, salt.
Always solution, no powder. Very important basic points. Always solution, not powder. Never apply powder. Number 1. Clear instructions to the patient. inside the patient that you're going to keep drop of solution, and he has to identify the solution which is sweet, sour, bitter or salt. Yes, salt, and he has to give the answer in the form of, you know, prepare the patient for answering by maybe number or color coding or ask him to write down. Never ask the patient to verbalize the answer of which solution you have kept. Never ask the patient to verbalize that one. Okay? In whatever way you want to do that. Prepare the patient for writing or some sort of numbers or fingers and make them to do it. Okay?
After
And another important point is always put the tongue slightly on the floor. Okay? Then you try to apply on one half of the tongue, anterior part, then other side to be checked. Before moving on to the other side, always ask the patient to rinse the mouth, then moving on to the next side. So only one side, solution, a drop of solutions to be kept. Ask the patient to answer which solution has been kept over there, followed by rinse the mouth, followed by moving on to the next side. That's why you're going to check for the taste sensation. Okay? Yes. Which is the order ideal one to go for? Can you keep bitter to start with?
No.
Bitter is always the last solution to be kept. Okay, sweet, salt, then sour, followed by bitter. This is the order always try to go for. Don't change the order. Okay? Sometimes you get different types of receptors stimulated to produce a different perception of the taste sensation subsequently after application of the bitter taste. Right? Yes.
Special senses.
Posterior 1/3. Similar to that, but carried by glossopharyngeal nerve, 9th nerve. Yes, this is basically the sensations you're supposed to look for. Special sensations and musculature or power or motor part we already discussed about. Go to the 8th nerve. 2 components.
8 now we have to check the first
Single person. I will check.
First I will ask the patient if he has any ear discharge or ear block. After confirming that he has no problem in the ear, first I will rub the index finger and thumb finger near the ears of the patient and check whether he is able to hear it. If he is able to hear it, I will proceed with the Rennie's test and Weber's test.
2 important components, vestibular component, cochlear component. Okay, yes, he is going to check for now.
Vestibular, cochlear component. உங்களுக்கு ஏதாச்சும் காது கேட்குற பிரச்சனை
Also examine the patient. So asking for is okay. You also examine the ear canal, any discharge is there or not. How are you going to look for that? It's also basic clinical examination. Show me how you are going to look for the canal. How are you going to do that? Ask the patient to sit straight. Then put your upward, outward. Yes. Check raise. Down. Look at the, yeah. Should be able to, in a proper way, maintaining, cannot be able to see the eardrum. Should be able to see the eardrum also. Unless there is any wax or anything obstruction, may not be able to visualize the inner part. So by looking that, you are very clear, even though you ask for the patient, you are very clear that you are not dealing with any block. Okay, yes. Then, which tuning fork you are going to use? We start from 256, 512, 1024 watts. But don't use 128. 128 is only meant for sensations. Only meant for, because of
you can feel the vibration from 10.
It lasts for 15 to 20 seconds.
its lasting time is longer time. That is called a slow decay time. It's called slow decay time. That's the basic reason. We're going to check for the lower limb and the upper limb. Always should have a vibration should be carried to the level of spinal cord, transmit the sensations to the level of higher centers. For that, you should have a vibrating tuning force should be having the long decay time or slow decay time, long decay or slow decay time. So that's transmitted through from the periphery to the center point. So 128 is used for this vibrating sensation, whereas 256, 512, I load is 512. Then 1024 can be used for Rinne's and Weber's test. Good. What's the basic principle you should know?
Air connection is better than
Always air condition is better than bone condition. Air condition is all these basic principles you should remember. AC is better than BC. Okay, yes. அதில் மாதிரி கேட்கக்கூடாது, அதில் மாதிரி ஃபீல் கேட்கறது ஏர் கண்டிஷன். எஸ்,
அது எப்போ நிற்கிறதோ அப்போ நீங்கள் வந்துட்டு கை தூக்கி காணும்.
வெரி குட் எல்போ, குட் குட். Always keep it over here. Don't think it is vibration. தெரியுதா உங்களுக்கு? ஒன்றுமே தெரியலையா? என்ன தெரியுது? கை வச்சு பாருங்க. It is not the sensation of touching. You should be able to appreciate the vibrations. இப்போங்க சவுண்ட் தெரியுதா? அதுவா தெரியுதா? கேக்குதா? சவுண்ட் கேக்குது. Still is not able to appreciate the vibrations. புரியுது? கேக்குது. So he was not able to appreciate clearly. He was not able to appreciate clearly even the vibrations. After a few seconds of placement over the mastoid but just placed in front of the ear canal, he was able to appreciate that. He is able to hear the vibrations. So the basic point you remember is keep it over the mastoid region. Then after a few seconds of a placement, try to keep it over the in front of the ear canal. The person is able to hear the means. Air condition is better than bone condition. Normal air condition, bone condition. That's how you can interpret from the Rinne's test. Okay. Whereas Weber's test.
ஐயா நான் இப்போ வந்துட்டு இந்த வைப்ரேஷனையும் உங்கள் நெற்றியில் இருக்கேன். உங்களுக்கு வந்துட்டு எந்த சைடு வந்து அதிகமாக ஃபீல் பண்ண முடியுதுன்னு சொல்லுங்கள். எந்த சைடு அதிகமாக ஃபீல் பண்ண முடியுதோ இல்லை ஒரே மாதிரி கேட்குதோ எப்படி கேட்குதோ அதை நீங்கள் வந்து
The vibrating tuning force should be kept at the midpoint, maybe over the vertex or over the globular, this one point. Center of the forehead also, over the vertex or here, both sides are acceptable. And ask the patient to which side is able to appreciate the vibrations better. Normal expectation is both sides equal. Both sides equal. Okay? But the problem here is sometimes the patient might not be able to appreciate the vibrations. So very important. Suppose we are finding very difficult, don't manipulate the answer. Tell the examiner it's finding very difficult to appreciate the vibrations. Doesn't mean that the problem in the nose conduction capacity, right? Yes. அது உங்களுக்கு தெரியுதுங்களா? ஒன்றும் தெரியல. வெச்சது மட்டும் தான் தெரியுதா? She is not able to appreciate very satisfactorily both sides the vibrations. Doesn't matter. That's how you are going to check for it. Okay? So limitations can happen in the examination. Practically also to try to make a clear point to the examiner the limitation of the examination capacity. Stop that. Okay? It's not wrong. You will not be penalized for that. Okay? Don't worry about that part. Then move on to the next clinic. So both are checked together. Areas. Expression palpation.
First, I will check the uvula, position of uvula.
So always place the examiner has to place in front of the patient. Then
I'll ask the patient to open the mouth.
open the mouth. What are the prerequisites? Starch is required. One more thing is required.
Tongue depressor.
Depressor, or you can use the spatula also, or orange stick also. These are the few requisites for your examination of the 9th and 10th cranial. Okay? Yes. So we look at the
ஐயா வாய் நல்லா நாக்கு வெளியே நிற்கும்.
go back and kneel down. He is trying to look for the 12th cranial. Why? Ask the patient to open up and look at the soft palate and the uvula part and then look at the pharyngeal part. But if these three parts to be looked for 9th and 10th cranial, except for the posterior 1/3 which you already discussed it. Okay? Yes. Never ask the patient only to protrude. Suppose very much hiding, the tongue is big, macroglossia. Then ask the patient to protrude the tongue. But try to look at the majorly on the soft palate and the uvula part and the posterior pharyngeal part. The placement has to be looked for center or deviated. Okay? Yes.
Check for palatal reflex and gag reflex. Palatal reflex by using a swab,
Ideal one is orange stick or spatula with a soft cotton can be applied to try to touch the
posterior pharyngeal part.
that is palatal reflex. It is pharyngeal reflex. Why confusion? The palatal part has to be touched and find out the reaction is going to be palatal reflex. The posterior pharyngeal wall to be touched and find out the reaction is going to be, what is the afferent? Afferent, glossopharyngeal now, efferent, vagus now. So 9 is afferent, 10th is your efferent. Okay. So by looking at that positioning, number 1, touching the part, you will come to know is it an afferent defect or efferent defect. Is it afferent defect or efferent defect? Okay. Yes. So afferent can be defective, in which case you don't get any motor response. Right? You're going to touch. The touching part is not having any sensation. 9th now is lost. So you don't get no response at all. Okay? Ask the patient to make a movement of the pharynx. Make the patient to make a noise of ha. You'll be able to move. That means the pharyngeal muscle is intact. That is vagus is intact. But touching, no movement. You can understand I am dealing with the afferent defect. So always look at the patient, inspect the part, ask the patient to make a noise of maybe letter like you can make the patient to make an attempt to make a noise of ha. The movement is happening, you are very clear that you are having the efferent of the pharyngeal reflex is intact. Touching, no response, that means afferent is defective. All of you able to follow? Afferent defect versus efferent defect. Yes. Then the palatal part, soft palate, the palatal fold to be tested to find out the reaction of the soft palate. Okay? Uvula. Okay? Yes, that is for your. So both the things should be carefully handled because very much discomfort to the patient. You are touching the posterior part of the oral cavity. So please see to that you are comfortable making the patient accept the examination method. Okay? Yes, 9 and 10. Then
11th for any grouping of the shoulder or any deformity in the limbs.
what are the muscles supplied by it? Sternocleidomastoid, trapezius. Okay? Yes.
For checking sternocleidomastoid, I'll ask the patient to
Before they started with the trapezius, finish up the trapezius.
trapezius. I'll go to this patient.
So always examine for the trapezius anteriorly, posteriorly. Ideally examine from the posterior aspect. What are the additional clues you can get from the posterior aspect looking at the if the defective trapezius involved? Yes. The scapula border to be looked for. Very, very important scapula border to be looked for. It is not a defect of the nerve supply of your. It's a defect of 11th cranial we try to look for. So always try to look for the shoulder level or the shoulder blade level or the trapezius level. As was mentioned, slightly amount of drooping can be there along with the border of the scapula to be looked for. What is the positioning? Then followed by shrugging of the shoulder. Followed by power to be assessed by the shrugging of the shoulder to be looked for. Okay? Yes.
நீங்கள் வந்துட்டு ரெண்டு இதையும் நீங்கள் மேலே தூக்கணும். தூக்கும் போது நான் வந்துட்டு உங்களுக்கு என் கையில் நான் கீழே அழுத்துவேன், நீங்கள் அதுக்கு எகென்ஸ்டாக மேலே தூக்கணும்.
Enough. Then stand examined from the front, right? Positioning of the neck, expression wise. Suppose right sternocleidomastoid is defective. Right side is defective, it is not functioning normally. Left side is normally functioning. What is expected? Opposite side? So what we get? What is the sign? So it is not the problem of trachea, it is not the problem of upper lobe fibrosis or any other deviation because of tracheal deviation. You can get the sternocleidomastoid involvement also, you can get the prominence of a sternocleidomastoid because of the 11th cranial involvement. Always keep it that also in mind. Where you can get the trials and can be positive in case of 11th node involvement also. Yes? Yes. And look for the prominence of the sternocleidomastoid and the power. Unilateral muscle to be checked for, asking the patient to turn to one side and offering the resistance and find out. It is not only offering the resistance and finding out, always try to palpate the sternocleidomastoid. Very important. Always try to palpate the sternocleidomastoid. Similar to that, the other side also can be checked for offering the resistance and palpating the sternocleidomastoid. The both sides together, ask the patient to chin down and against the resistance and try to palpate the sternocleidomastoid. So everywhere the muscles, whether buccinator muscle, masseter muscle, frontalis muscle, whatever the muscle, try to inspect and palpate. Always try to feel the muscle. Applicable for your motor system examination of the limbs also. Okay. Yes, that feel. Yeah, correct. Yes. Now both sides. Kilapara. The resistance is not good. It is very much resisting your resistance or overcoming your resistance. This is about the 11th cranial now. Moving 12th cranial, the last cranial.
I'll inspect for the tongues. Yeah, not very. I'll check for any wasting of the tongue or atrophy.
First, always 12th cranial inspection wise, place the tongue in the floor of the mouth, examine for fasciculations, then followed by any wasting, any bulk, increase in the bulk also. Okay, these three things to be looked for. Then followed by protruding the tongue out of your oral cavity and try to find out the tip of the tongue, not the angle of the mouth, not the angle of the jaw. You are supposed to concentrate only on the tip of the tongue. Very, very important, deviated to that, which direction. Normally, what is the clue? Which are the muscles or which are the cranial nerves will produce same side deviation? 5 and 12. Okay, which muscle is defective here? 12th cranial nerve? Somebody said genioglossus. Correct. Genioglossus, the muscle is defective. It has got a tendency for pushing muscle. Okay, so it has got a defective, producing the defective is same side. Okay, yes, go ahead, show me that.
Hello. Sir, there is no wasting of tongue muscle and then there is no fasciculation.
Always tongue has to place the floor of the mouth. Throw the light clearly. Throw the light. Yes. minimal deviation, but it is not a true deviation. You may make out that the difference in the tip of the tongue, right? It's keep on changing. That means it is having bilaterally, power is normal. Okay? Yes, then followed by the tone has to be assessed. Power has to be assessed. Keep the finger, yeah, correct. Always feel the muscle of the tongue. Wear a gloves and try to feel the tongue muscles. This is another part of your examination, the tongue examination. Okay? Yes. You can get wasting, you can get deviation of the tongue. So two important things can be checked. Power or the tone also can be checked for the 12th cranial. So the basic components of the 12th cranial. Okay? So a quick recap of your examination. The prerequisites for cranial 1, 2, 3, 4, 5, 6. 1.
The patient should be familiar with this first.
Just quick recap. Okay? Only 5 minutes time.
He should not be having any nasal polyps or septic.
Nasal examination applicable for ear examination also. We try to finish off that. Familiarity should be there. Don't keep irritant material. Don't keep irritant material. Okay? Yes.
Eyes should be closed before smelling the
Object or substance. Sorry.
we have to check one nostril at a time and
Followed by the other one. Okay? Eyeball. Regarding this cranial 2. Visual acuity. Visual field. Color vision. Okay? Visual acuity.
Yes,
We have
yes.
a distant vision, near vision. Visual field. All the directions supposed to look for. But don't cross. Always try to bring the object from away from one to. Okay? Yes. For lateral vision. Okay? Then always use the Saravanan chart and the
Ishihara.
that's for that. Near vision.
JS.
Vigas chart should be used, whereas Ashigara's isochromatic chart will be used for color vision. Okay? Yes. Then 3, 4, 6. The placement of the patient has to be very proper. At least 1 meter distance to be placed. Look for the eyeball movement. Always use the H technique or H method of examination. Always never forget to check for the upper quadrant, lower quadrant. By doing this H method, you will not deviate from that. Very important, never try to bring your object crossing the midline for examination. Okay, both applicable for visual acuity and field of vision. Always try to do that. Never try to bring in the object crossing the midline. Then
We should inspect also for any
doses and other things are there to be looked for. Okay, yes. Fifth now, motor part and the sensory part. Motor part always try to look for the jaw angle, but not a common one to have a deviation of the jaw angle. The reflex part is concerned, never forget conjunctival, corneal and the jaw jerk. Okay, whereas sensory part is concerned, we have the individual branches of the cranial now. But very important, keep in mind, you can also check for the tip of the nose to the tragus. The audience skin appearance of the distribution of the defective sensory part. Okay, always remember about this ophthalmic. Very important clue is going to be angle of the mandible is not supplied by fifth nerve. The only part in the face is not supplied by fifth nerve, supplied by C2 branch of the cervical nose. Okay, then it's for the sensory part. Reflex part we discussed. Then seventh nerve. Always look at the upper half and lower half. Always look for the frontalis muscle, followed by nasolabial fold. Always look at the buccinator muscle. Then always look for the orbicularis oculi, followed by orbicularis mores. But you should know the differences between the upper motor neuron type of facial palsy versus lower motor neuron type of facial palsies. Never forget to look for history and examination of the hearing and these are the basic learning points you take home. Okay? 2/3 of the tongue, never forget to examine. Always examine the anti-2/3 of the tongue. Then follow the 8th now. The two components, vestibular component which you have not discussed, whereas cochlear part you always try to look for the Weber's stress and the Rinne's stress. Very important basic point, air condition is always better than air condition. Always try to keep it over the mastoid portion, the vibrating tuning fork. Don't use 128 frequency, always use 512, 258 or 256 or 1024 also acceptable. Then once the patient appreciating the vibrations, not hearing the vibrations, appreciating the vibrations, try to bring in front of the ear canal to find out is able to appreciate or not. If is able to appreciate the noise, that means the air condition is better than bone condition. The V burst is always laterally to the disease side. Suppose if it's equal, normal response. Okay. Followed by 9 and 10, always look for the palatal side or the positioning, followed by a palatal fold, soft palate, uvula and the soft palate, followed by pharyngeal positioning. Always try to look for the sensory part, touching the posterior pharyngeal wall and the palatal part. Look for the response in the form of movement of the uvula or the pharyngeal wall to be looked for. Okay, and followed by your 11th cranial nerve, always look for the trapezius. Never forget to examine the posterior part also for the trapezius examination. Always move to the front for the sternocleidomastoid examination. Check for unilateral followed by bilateral. Important take-home message is always palpate for the muscle belt, try to assess the power of the muscle. Always can expect some sort of prominence of the sternocleidomastoid. This trial sign can be passed in case of 11th nerve also. And 12th cranial nerve, the tongue examination, you always try to go for the positioning and what exactly the situation of the tongue and the floor of the muscle, the form of vesiculation is there or not, any wasting is there or not. Ask the patient to protrude the tongue, look for the tip of the tongue, any deviation is happening or not. For the power has to be checked by the pushing of the cheek and try to palpate for the power of the muscle, of the tongue muscles. Always deviates to the side in the form of genioglossus because of this genioglossus wasting or weakness. Okay, I think these are the few quick recap of the clinical examination of cranial nerves. Anything else to be mentioned, sir?
Unconscious patient.
Unconscious patient. Yeah. So what are the things you can pick up in the unconscious patient? Patient in the emergency department, lying in the bed, brought to the emergency department or casualty. What are the things can be picked up? Patient is not communicating, nobody is there. So patient is brought to the emergency department. What are the things can be picked up? Starting from top to bottom. Always when you have a patient of that nature, you are more concentrating on the cranial nerve part. Anything else can be picked up. Pupillary reflex can be picked up, yes. So eyeball positioning also can be picked up. So in the unconscious patient, the toes is very difficult to pick up because the toes is examination has to be done in a sitting posture. Never try to look for to say that the patient is having toes in the lying posture. Ideal position is to look for the toes in the sitting posture, not in the upright posture, not in the lying posture. It's very difficult to make a comment on the third now, but you can definitely make the eyeball positioning followed by pupillary response. So in which case you can make out 3, 4, 6 as soon as you are. Once again the light reflex and the pupillary reflex, accommodation reflex can be checked for. Problem here is accommodation reflex cannot be checked for in an unconscious patient because patient has to fix the object distant followed by nearby, then follow anything else. So gross deviation of the facial deviations can be picked up. Gross facial deviations can be picked up. Okay, then anything else. Anything else. The palatal reflex and the tongue examination is very difficult to perform in the unconscious patient. So only few things, eyeball, yes, very good information you will be able to get. The nasolabial fold, sometimes you can get the information. The other part is very difficult to get, but other examinations to be carried in an unconscious patient.
Doll's eye movement.
Doll's eye movement, yes, good. Then, anything else? Other than the cranial nerves. Position of the patient, yes, good. So attitude of the limbs. Attitude of the limbs very important. Sometimes you might see fractures, sometimes stroke also. Okay, deficits can be there. Anything else? Can you perform the Kernig sign in case of unconscious patient? So you have to do the neck movement also. To look for before that, see to that you are not dealing with fracture. You are not dealing because we are dealing with the unconscious patient. Very important. Then you can also do the Brzezinski sign. We have a neck Brzezinski sign and as well as leg. Both can be carried. Okay. I think we'll stop here. the other person has come. We have a quick recap whatever we learned, try to practice and try to go back and start.